Hi, welcome to the Facebook Live, and we are celebrating today the 30th year of the foundation of Indian Society of Critical Care Medicine, and to commemorate that we have two very important, I would say, compatriots, guests, and some of the most important members of the society. We have Dr. Mayur Patel sir, who is the mentor of Department of Critical Care Medicine in Reliance Foundation Hospital, and also the first Vice President of the Indian Society of Critical Care Medicine. And we have Professor Dr. Rahul Anil Pandit, who is the chairperson as well as the director for Critical Care Medicine and Emergency Medicine for Sir H.N. Reliance Foundation Hospital. Also, he is the chair of all the healthcare initiatives of Reliance Foundation. And he has also served as both a vice president of the Indian Society of Critical Care Medicine, as well as he was the organizing secretary for the annual national conference of Mumbai in 2019 for the Indian Society of Critical Care Medicine, which happened to be the 25th year of the society. So why today we have a little bit of background that why we are discussing here in Sir H.N. Reliance Foundation, but we will listen it from none other than Dr. Mayur Patel. Sir, what exactly happened on 9th of October in 1993? And what is the relationship with H.N. Reliance or the H.N. Foundation?
So what happened was, in 1987 February, a new ICU was started in old H.N. Hospital. I joined there as a senior resident, and the chief of the unit was Dr. Praveen Jain. There were 3-4 of my colleagues who were there. We started working in the ICU, and over a period of time we realized that critical care medicine is going to be the future. We got support from the management of that time, and subsequently few other senior colleagues like Dr. P.J. Mehta, who was very active in Association of Physicians of India, and Dr. S.K. Bansali, who was a surgeon. They actually pushed us that you should develop this branch, and Dr. P.J. Mehta talked to us and gave us idea of how to go about building a society. So we, 3 of us, Dr. Praveen Jain, then there was a lady called Vidula Vacharajani, she was my co-registrar, and myself. 3 of us sat and started thinking how to go about it. So we approached the medical faculty of Old H.N. Hospital, took their opinion, and everybody was welcoming it. So at least a core group was formed of 3 people. Then we approached none other than Dr. Udwadia. Of course, initially he was little taken aback that how can you people start this society? There was a lot of push and pull going on for quite some time, but finally he gave us his blessings. Then we invited physicians from Bombay, and we met in Oberoi and formed a group of Indian Society of Critical Care Medicine. Of course, before that, me and Dr. Jain had been to various places, especially Delhi and northern part of the country. We met a lot of anesthetists who were managing ICUs in G.B. Pant Hospital and other hospitals in Delhi, and they also welcomed it. And that's how the whole thing started. So the first meeting took place on 9th October at Oberoi, and that's how the society actually was formed.
But the concept formed from the department
It was
in
the-
was
It was in
erstwhile
the old
HN.
library of HN Hospital.
Okay.
That was the place where we were sitting and discussing how to go about it.
So coming to Dr. Pandit, so what had been the journey? So 93, a handful of people, residents and a consultant forming a society. So if you may tell that how the Indian Society of Critical Care Medicine has gone to what extent in these 30 years?
I think the journey of IICCM has been really superb, I would say. It started off with a handful of physicians who had the vision to actually establish the society. Then I think the game changer was that they decided to dedicate most of the time of the society for education. And that's how the conference started. The annual conference started a year later than that. So 1994 was the first conference, which I believe was oversubscribed by 3 times the capacity which the hall could actually take. And that's how people started realizing that this is a specialty and there is this niche group of people who are able to understand the physiology and apply it at the bedside a little differently than what the normal physicians and surgeons do. And slowly the society started sort of having more and more members. And then need came up that there was no specialized training actually being offered anywhere in the country. I am a classic example of that. When the society sort of started the Indian Diploma in Critical Care Medicine, which was first a certificate, then it sort of graduated to become a diploma.
I think that very year you went to Australia.
That same year I went to Australia. And I think that's where the change was. The society had the vision to not only give education, but to actually formalize the training and bring out trained intensivists. And this is where I think the game changer was. And then there was no looking back. I think it grew from leaps and bounds, hand to hand, people sort of started appreciating it, more and more trainees joined. And if you look at today, there are more than 200 institutes, you know the latest statistics, and I believe more than 200 to 300 students graduate as diploma holders of IICCM every year. And over the last 27, 28 years of the diploma course being conducted, we must have produced at least 2,000 to 3,000 people who are
3,000 and above.
3,000 and above.
So to give you the exact figures, sir, I think we have close to 400 hospitals enrolled with the Indian Society of Critical Care Medicine. For almost now we have 15 different courses, including the standard Indian diploma, with Indian fellowship, with diploma for the nurses, allied healthcare personnel. Now super speciality and subspeciality are coming. But coming back, this is I think what society has contributed, making, and I think this contribution actually worthwhile worked during the COVID itself.
Yes.
So if you see that the number of intensivists who worked in COVID saved our country, India's performance was one of the best in the entire world. I think the society trained intensivists were overwhelmingly large, almost 90% of that. So if you, both of you, I will start with Patel sir, that if you say that what is the perception of critical care medicine amongst or the intensive care, though it has improved a lot after COVID, but to easily, lucidly explain to the non-medical viewers what's here.
See,
So what is critical care medicine?
Initially, it was very difficult to convince people, even in the medical field. But I would name a couple of people who actually were after it. One of them was Dr. Bansali, who was a surgeon, but he believed in, specialized care for surgical patients. Second was Dr. Praful Desai from Tata Memorial Hospital. Now, just to go a little bit behind, the first conference was held at Tata Memorial Hospital, and Dr. Praful Desai had willingly given all permissions to utilize from Tata Hospital for the conference. And as he said, it was phenomenal. And Dr. Udwadia was our guest speaker for the conference, and he gave an oration, first oration of the society. And believe me, the hall was jam-packed. So the surgeons have played a very important role, according to me, in pushing the field of critical care medicine, because they realized that when they operate high risk cases, they require backup. And they backed us to the T. Tata Hospital being one of the pioneers in surgical oncology, they required. So there is a lot of people
who supported
at Tata also. And gradually once they saw the outcomes, believe me, in that old ICU when we were having out of 6 beds, 5 of them would be cases of acute pancreatitis with, you name the complications and they were there in the patient. So it was a real learning experience for different fields also, like nephrology, cardiology, surgeons, everyone. Everybody had to participate, and it became like a multidisciplinary approach for pancreatitis. I vividly remember
and where critical care was actually intermingling and
with
coordinating
all
the
the,
entire,
yes, absolutely.
entire care.
And-
And also there was a palpable difference in the outcome which started to
Yes.
happen. So, Panditji, what would you say that, how would people perceive the critical care, general people?
I am
Because
just
people
going
don't
to-
have an idea, they think once patient goes to ICU, the outcome is not good. What does an intensivist do? So, if you can
I'm
please.
just going to put it into a very simple way so that common people understand. So, you know, when people come to ICU, they are in that phase of life where actions matter, the right decisions matter so that their life can be saved. So, I would like to give the example of an army. You've got generals, you've got soldiers, you've got majors, you've got colonels, and then you've got the black cat commandos. So, the intensivist is the black cat commando who comes, who does the action, and he sort of goes away. And then the major and the general and everybody can go and sort of look after the other things. But those black cat commandos, that 1 day, 2 day, which makes the difference, is what the intensive care training is. So we are trained to be that black cat commando, a jack of all trades. We can do the what a army person can do, what a navy person can do, what a Air Force person can do. And at the same time, we can do it with precision, in small time, in short time, identify the problem, treat it and go away. So that's how I would like to put it. This is, intensive care is equivalent to black cat commando.
Is an excellent example, I would say, right?
Yeah.
Better amongst the equals.
Yeah.
So we can say that on that. And as a specialty, I heard a analogy. I would like you to also explain on that. That intensive care works just like how a brake works in a motor vehicle.
Yes. So I was going to come to that again. That, you know, if you equate a hospital to a Ferrari, and the fun of driving a Ferrari is that you should be able to drive it at a speed you want. And that speed is given by your other departments like cardiology, neurology, you know, the hospital runs on those departments. But they are able to do and accelerate on that because they have the comfort of brake and the seat belt. And that brake and the seat belt is critical care. They know that if something goes wrong, they are going to actually hold us tight. And that's how I would sort of, these are the two examples.
I think Patel sir would agree that with the extensive and very elaborate, competent critical care, all the other departments feel safe
absolutely
to go and
absolutely.
expedite and go more adventurous about their processes and all others.
Absolutely, agree.
So I think that's the comfort or the assurance a critical care gives to all other specialties to go ahead and fulfill their wishes. And we say that while you are taking care of the patient, we are there to take care of your needs too. So in that sense, we would come to a little bit of the end of the program. But before that, we would ask both of you, I will again start with Patel sir, that how do you look? You have seen the 30 years of the progress of the society. So how would you look in the next 20 years? That what do you expect? What would happen?
Technology has changed tremendously, and ICU has grasped it with open hands, and we know how technology helps us to monitor a critical patient. So there is no question technology has helped us. Simulation based training is very important, and as you know, to man the ICU we require trained people. So training of future doctors has to be in critical care. This is what my take on.
So more tech based, you're on the, not only on the treatment but also on the training.
Yes.
Mostly on online training you were talking about.
Yes.
And also simulation based. I will come to Dr. Pandit on that. Your question would be a little twisted on. So not only the future, but I would rather say that if I can ask you the top problems of the intensive care right now, and in coming 1 or 2 decades, how they are going to be solved only by us.
So I think the top couple of problems which are glaringly there is that there is a drive towards super specialization of the critical care now.
Okay.
You see that there is a fragmentation of critical care, neuro society, cardiac society, nephro society. I think all of them, it's going to develop, just like surgery developed into 10 different branches, you will see critical care specialty also developing into a little bit more branches. But as long as they all hold hand together and move forward, I think there is no need to be worried about. That's the first thing, and that's where the problem solving comes, that the helm at the person is at the helm at the affairs needs to have a joint collaboration with all of these different people who are sort of into a specialized critical care only. That's one of the problems. The other problem is that our specialty is highly demanding and high burnout, and people are now, I have spent around 25 years, you are similar, sir is more than 30 years experience, and this burnout is now really being talked about quite a lot, and that is probably going to give us a little bit of a negative feedback as a specialty. People may not choose our specialty as a first specialty to work in, because you have to put in 20 hours a day at times for a number of days together, so no rest, nothing. So I think that burnout factor will have to be taken care of. We will have to train more and more doctors so that we can have specific times where the productivity and the efficiency of a doctor is the best, and say after 10 hours, pen down, books off, you are out of the ICU, you go and relax, let the next team come and look after it. And countries like Australia, Canada have done that efficiently, where they give their doctors adequate rest after one shift, so that, or after a period of 3 or 4 shifts, so that they
come back rejuvenated.
refreshed, rejuvenated, and are able to give the best again for the next 3 or 4 days, whatever their posture. I think these are the 2 big challenges in front of us.
To both of you, on the concluding remark, the cost for general public, right? Everyone thinks that being in an ICU is a costly affair, which it is, right? So how can we solve this conundrum, that to give the best possible care, but within the reach of everyone's means, how we can do that?
It's difficult, but unfortunately the cost has gone up because of various reasons, costly medications, costly treatments, newer modes of treatment coming in. So to tell you frankly, I don't have the answer for that, but we have to have sustainable ICUs. Resource utilization has to be proper, and try our best to cut down the costs in a positive manner.
Sir.
Yeah, I think one of the ways of sort of bringing down the cost is to look at tele-ICU, for example, which we are doing. The second way of doing would be to, and India has progressed to some way. The leadership from the Honorable PM itself is Make in India. I think a lot of these medicines and devices which we are using right now are unfortunately imported. So as their things start getting made in India, we will be able to have better medicines available at a cheaper cost, better devices available at a cheaper cost. And I think at some stage, the country will only go into public-private partnerships. What will happen is that you will always have a set of people who will sort of offset the cost for the other set of people to work in. And there is a huge push for the public-private partnerships to happen. And I think that's one of the, it's a low-hanging fruit. If it works well, if there is a proper term of reference given, it will actually work very, very good for the poor people who are not able to get the same class of treatment right now. So that's the way forward. And tele-ICU, of course, I think Dr. Kar, we do it now for villages which are in far north, hospitals which are in far north. And trust me, just doing simple things like the fast hug BID on a dedicated way is making a big difference to their outcome. So we are not.
I think that will make critical care more equitable, right?
Yes.
And accessible to all on that part.
Basics also will change.
on
at the
that day.
interior level.
So, one-liner concluding remark on the 30th anniversary of Indian Society of Critical Care Medicine, sir. What would you say?
It will,
one line.
it will grow further.
Okay, so
That is
you are contemplating a further growth and the
Yes.
society becomes much,
Much
more
larger,
bigger than what
yes,
we are.
definitely.
Sir,
Well,
your one line.
it has just come into the prime. It is a youth right now. It has just come into, we have got still, the best is yet to come. I think another 10 and 15 years when it will be 40, between the 40th and 50th year, I think
Just
it
like
will
a-
actually,
like the medical profession,
just like a
yeah.
medical profession, I think it will blossom into a very, very different kind of a society, which will be inclusive, which will actually allow people to do a number of things. I think one thing which the society probably should do, and there is a push about it, but I don't know how much on the ground we are, is some basic research. We need to have Indian data, Indian research published out. I think that's what society should look at, and it will give us a very different name, just like the SCCM or the ANZICS or the Singapore Society.
Fair enough. I think we take a leave and we will come back soon on different programs on the Facebook Live. Thank you.
Thank you very much.
Thank you very much.
Thank you.